Great. Well, thanks everyone for coming. My name is Chris Simmons. I'm the Associate Vice President for Federal Relations at Duke, and this is part of a 7 or 8-part series talking about the midterm elections, where we have professors and faculty here at Duke and experts in Washington, D.C. talk about different aspects of the midterm election. And today we're talking about healthcare, and we're excited to have Professor Don Taylor and Jim Capretta in Washington, D.C. Jim, thanks so much for coming. Don, thank you for coming. Just really briefly, Don Taylor is an Associate Professor of Public Policy and the Associate Professor of Community and Family Medicine. Is that right? At Duke at School of Medicine? Is that your correct title? Close enough. His research focuses on end-of-life care, specifically on areas of patient decision-making and Medicare hospice policy. He's been an active voice on the ongoing debate over the Affordable Care Act, writing 29 columns on healthcare, health reform for the News Observer, as well as contributing to New York Times Room for Debate forums. And you recently authored a book on healthcare reform, healthcare policy, developing long-range balanced budget in the United States. And then Jim Capretta is a Duke graduate, Master's in Public Policy in 1987. Is that correct, Jim? And you spent more than 2 decades studying American health policy, including time at the White House on the Office of Management and Budget, and where you were responsible for healthcare, Social Security, welfare issues. I think I first met you when you were on the Budget Committee in the Senate, or could have been the House Ways and Means Committee. I know that you've made your rounds. You are now a senior fellow at the Ethics and Public Policy Center, as well as a visiting fellow at the American Enterprise Institute. And I recently just read something that you wrote with one of Don's good friends, Yuval Levin, on the how to transition from Obamacare to real healthcare reform. And we're excited to have you be a part of this. I also want to thank Professor Laurent Roy and the Forum for Scholars and Publics for helping co-host this. So I think what we'll do is we'll let each of you just talk for a few minutes about your thoughts about the Affordable Health Care Plan and its impact on the midterm elections, and then we'll open it up for questions from our audience here in Washington and then in DC. And Don, if you'd like to start, that would be great.
Sure. I think the short answer of how will the Obamacare affect the midterm elections is that I'm not really sure. I have some uncertainty about that. I will say that just taking a North Carolina frame, this is a battleground state. The Speaker of the North Carolina House, Tillis, is running against Senator Hagan, and it's a key race for who's going to control the Senate. And in January and February, there were tons of ads run that were focused on the Affordable Care Act against Senator Hagan. And I know that this fall, most of the ads are focusing either on just the generic issue of spending or education. So I think in many ways, Obamacare has drifted a little bit to the back burner. I think part of that's just the reality of the fact that 350,000 North Carolinians signed up for private health insurance through the Obamacare exchanges, and this state was one of the, depending on how you measure it, one of the ones that had some of the highest rates of uptake. So I think those practical results have muted some of the political effect. I wrote a book 3 years ago that proposed a health reform deal between the two sides, meaning the Dems and the Republicans, and basically said a political deal is inevitable. And there's some policy issues that actually policy analysts on both sides of the aisle, roughly speaking, agree about. And really, much has changed since then in terms of that. At some point after the 2014 election, the incentives are going to shift and the time will be right for a political deal. I think paradoxically, if the Republicans took the Senate in 2014, I would actually expect a deal between President Obama and Congress before he leaves office. If the Dems hold the Senate, I'm not really sure. We can talk more about that, including about ins and outs of plans. But a lot of people might be surprised. I'm a supporter of the ACA, and I think Jim would say he's not a supporter. But in policy terms, if you read what we wrote, there's actually quite a lot of agreement. And sort of underneath the noise for the policy folks, there's quite a lot of agreement.
Great. So, Jim, are you a supporter of the ACA?
research, so I think it's pretty well on the record at this point. But I want to start by thanking Duke for having me participate in this. It's nice to be with Don again, discussing this issue. We had to do it about, I think, 3 years ago or so, and it was enjoyable then. I think we fun to sort of provide an update to what we said back then 3 years ago. In terms of how what's going to happen here in the next the election time, first of all, it's important to realize that there's been no polling data for the last 4 years that has shown growing consistent plurality support for the law. It's been pretty steady, and roughly 55 opposed to between 30 and 45 support. And the opposition is has the intensity of it, as pollsters can do. The intensity of the opposition is basically twice the level of the intensity of the support, more or less. Of the 55 that are against, 40% are really against it. And of the 40 to 45 that are for it, about 20 are really for it. And so the intensity of the opposition far outweighs the intensity of the support. Now, Don is absolutely correct that the German, on the ground facts, of course, change the dynamic politically. And there are, depending on how you look at it, between, 12 million or so people who are insured now because of Medicaid expenses and various people that enrolled through the insurance exchanges. Of course, some of the 12 million is probably people that had to migrate from other insurance arrangements. So the net effect is still very much an open question. Okay. Recently, a little bit smaller, frankly, than the net effect seems likely to be a little bit smaller than people are claiming, and so we're going to have to wait and see if people really are able to that. But my larger point on the midterms is that it's going to be a regional effect. That in some states it's going to be very heavily play very heavily into the electoral outcome, and in some states not. Don's correct that in some states the ad, as measured by dollar effect on TV ads, the amount on the healthcare law dwindled to some extent in some states, but in other states it's ramped up depending on the sort of mood of developing those conditions. So I think in Arkansas, a lot of ads have been run on the Affordable Care Act in Alaska, and some other very key states, I think Louisiana as well. So it's a little bit of a mixed bag, how it's going to play out, and I don't think you can extrapolate from the circumstances in one state.
Jim, when you mentioned the polling data, a lot of people say, no, we don't like Obamacare, but there may be pieces of Obamacare that people really like. And when you dig into the polling data, are there some things that people say, well, I do like having my kid covered till they're 25, where the pieces of it broken out, there's more or less support in the variation of the polling data?
Yeah. I also have kind of an analysis of government policy in general. If you ask the American electorate, if you ask the public, would you like to have, free child care for all Americans in low costs and a robust defense program and, public health clinics on every corner? People basically say, yeah, that'd be great. I certainly would like to have my kid on free insurance, at somebody else's expense. And so you have to, the public is, if you ask them just slices, they're going to give you a different answer than if you ask, in general, based on all you know about the law, how do you feel about it, pro or con, which is a more fair question because there's lots of ups and downs in the law. You get intensity on the opposed side, not the support side.
Right. Good. Don, you had mentioned that there's a possibility for a deal, especially maybe if the Senate's controlled by Republicans after the midterm. And you said that there's a lot of people, maybe a majority of analysts and political people that are working on policy, that there's areas of agreement. What are those areas of agreement that you think people could come together and agree needs to be fixed, the specific pieces of the law that need to be fixed.
Yeah, sort of in no particular order, just some examples. I think there's been a lot of angst about the individual mandate, conceptually from conservatives, and I think that's heartfelt. But it's also a weak risk pooling mechanism. So doing away with the individual mandate and replacing it with some sort of a different way of pooling risk. Frankly, we've come up with ways that would do it better than the mandate that we have. So that's one. I think there's an interesting thing early, like in 2011, there was a lot of critique of the ACA about it was going to be giving free health care to people. And then once the plans got put out, we saw that, especially with the bronze level of plans, there's massive deductibles. So you have people with $7,000, $8,000, $9,000, $10,000 deductibles. And so all of a sudden you had Republicans initially saying, oh, you're giving it away, and then you had Republicans critiquing it for the deductibles too big. And then in fairness, there are plenty of Dems, I think, that supported the law that were kind of shocked at the size of the deductibles. And that's just a matter of how expansive the benefits are. So I think there could be some movement around what is a reasonable deductible. Like I'm not sure what the answer is, but it needs to be sorted out. Like what amount of somebody's income are we willing as a country to say that people should have to pay before insurance kicks in? And so if you join sort of the discussion of the mandate along with that, there's some ways to move towards some agreements that would sort of change or tweak the law. And then the last one, I think, most anybody that looks really closely at the law is worried about employment effects of the law. So that's both the employer mandate that's been delayed, and also anytime you have a means-tested program subsidy that starts at 100% of poverty and kicks off at 400%, you create very high marginal tax rates around the places where it starts and stops. Of course, the obvious answer is that we'll have universal coverage, but then so you have people critiquing both the breakpoints and the universal coverage. But the point here is that there's no perfect way to fix any of these problems. And the best way to fix them is for both political parties to have their fingerprints on the law, whatever the next step of the law is. So both political parties have a stake in working out the problems, because there'll be problems forever. We will never be done with this. So those are just three possible places of agreement.
Jim, would you add anything to that or disagree with any of Don's analysis?
Well, I think just back to his point was that I think if there was a Republican Senate and a Republican House in 15 and 16, that the possibilities for some of those compromises might exist. Perhaps I'm kind of skeptical about that myself. I think the the polarization around the law is pretty intense, and so I think there'd be probably a period of time, a pretty intense period of time, if Republicans did take the Senate, where they would feel compelled to, try to roll it back more or less. And I'm not sure that will be conducive to then coming around perhaps later in 15 or early 16 toward a deal. It might just, make the parties get even more divided going into the presidential election. So I'm a little skeptical about the possibility of that. Now, having said that, I do think Don is right that the individual mandate is probably ripe for being revisited. It's going to be, I think, end up being quite an unpopular provision, and that means that the support for it is likely to erode over time, and it's not really clear it's going to work very well. The administration itself has announced, major exemptions to it and is applying it to a pretty small sliver of the population. So, it may end up being something that can be where the two sides might actually agree on, jettisoning it for something else. I do think, though, that the larger question probably is, the larger point to make about all this is that I think there's one, I know maybe unfortunately from the public's perspective, and maybe even some people in these rooms' perspective, this whole issue is likely to get litigated one more time. I just don't think it's possible to kind of look at the scenario for the 2016 presidential election and not assume that the candidate on the Republican side, almost for sure to secure the nomination and to win the election, is going to have to be a critic of the law and outline a vision that is somewhat different from what the law provides. And the candidate for the Democratic Party is going to have to be, to some degree, a defender, but keep and improve candidate. And so I think that means that the issue of how best to go about all this is very likely to be litigated pretty intensely as part of the presidential campaign. It won't be issue number one. Growth will be, the number one issue in the next presidential campaign. But healthcare will still be a pretty important issue, I think.
So I have a couple more questions, but I want to open it up to people here in Durham and also in Washington for questions. Yeah,
I have one. This is coming from a historian, so pardon if it's kind of too broad and less about the midterm. But I'm thinking about other cases, right, where these kinds of programs were put into place in Western Europe or other programs like this in the United States. There's obviously this kind of process of settling serious opposition and then some kind of settling and then almost naturalization or normalization of certain practices, right? And the kind of the fact that people get used to a certain scenario. But I can't figure out whether those earlier historical examples apply to the present U.S. context and the healthcare economy that we have now, which seems so complex. And I kind of wonder if you can think about, are there effects, sort of economic effects around the world where healthcare works that would, one way or another really tilt the politics? When I try to read about it, it's pretty confusing. Obviously people are on a lot of sides, but are there things that could kind of develop over the next 5 to 10 years in the way that healthcare costs change or certain kinds of structural innovations or even ways that healthcare companies respond to provisions of the law that might affect this? I know this is a big question, but I'm trying to figure out, just as we project, I imagine the gridlock is going to continue, imagine, you're right, that this is going to continue to be a debate, but are there sort of things underneath the politics that may ultimately come back and change the political calculation that you can predict or think about, if that's a fair question?
Well, I think pretty much all Republicans now have had to say we support the concept of moving towards universal coverage. So once you've said that, you've boxed yourself in because there's not that many ways to do that. So it's going to take government intervention. So it's a question then of what type is that going to take.
So that's been like kind of accept that has moved to...
Well, I think they had this... I'm not sure there's anybody saying any longer that I just want to get rid of it and
would have to.
I mean, so it's that the ship sailed on that with the re-election of President Obama. So I mean, if President Obama would have not been elected, if we had President Romney, I think the law would have been repealed. But so that's gone, I think. So I don't think that it will go away, and so in that sense, it will. Be more. We're now both, whereas Republicans were generally very opposed to Medicare in the '60s, maybe early '70s. Now both sides battle over who loves it the most and who will save it. So the question is, what's the first political deal, and does it improve the policy? And then it's what's the next political deal, and so on and so forth. So I think this is the passage of the Affordable Care Act and then the re-election of the president, which meant that it was going to remain, is the most consequential thing that has happened in healthcare since the passage of Medicare and Medicaid. In 25 years, I'm not really sure what the health system will look like, but the ACA will have been the first step to that. Mm-hmm. So I think it is here, but I really don't know. There are a lot of different directions it could go. And I mean, the biggest question to me conceptually, and the way I think about it as a dad, do I want my children to get health insurance from a job? I actually personally say no. I think the concept of job-linked health insurance has outlived its usefulness for this country, but that is a profound change. Mm-hmm. And the problem is people with jobs, like people with insurance like Duke, if we do away with that, it's almost inevitably going to be worse for us. So it's a non-trivial problem to deal with.
Right.
Jim, do you have anything to add to that?
Well, I think the original premise of the question was, is there some something embedded in this law that would make it different from prior big social expansion provisions that eventually become, accepted and part of the social fabric, so to speak.
Right.
And I doubt there's anything that different about this law other than the way it was passed. The way it was passed was, in kind, and the times are different, and the way it was passed was different. And so, it has a certain intensity around it in the aftermath of that. But having said that, if the current projections are from the Congressional Budget Office, they think there'll be 24 million people in the exchanges in 2016, and another 10 or 12 to 15 million people on Medicaid. That's a big change that alters some portions of the populace's view of the law. A lot of people will be getting very discounted premiums based on that, and so undoing that easily would be, I think, pretty difficult. So I do think that there'll be, the longer the thing goes, the more it becomes embedded, so to speak, and change from it will have to take that into account. There have to be transition provisions if there are any changes.
Other questions here or in DC?
Yeah, I've got a question. So Dr. Taylor mentioned as one of the areas for a deal, these kind of massive deductibles, especially in the bronze plans. And I worked at a health insurance company this summer, and we ran kind of some basic analyses across all the plans to look at how much someone would have to spend over the course of a year if they maxed out their plan. And we found that it's basically the same across your bronze, silver, and gold plans, at least for the plans we offer, that you're going to spend somewhere between $8,000 to $10,000 a year if you combine premiums and then all of your cost sharing. And so I'm just curious how that factors into kind of this deal that I guess part of the assumption in that, though, is that people can anticipate which plan is going to be the best for them to buy, which is probably unrealistic. To say, if you're going to use a very minimal amount of health care, then the bronze plan is going to be your cheapest option, and if you're going to use some mid-range amount, then silver. And if you're going to really use a lot, if you have some chronic condition, then the gold's going to be your cheapest. But how that, does that relate to this deductible conversation that you were touching on, or?
I'm not sure. I think you were saying that you were working on some plans, and you're saying that if you look at premiums plus out of pocket,
Right.
you're spending about the same amount regardless.
Right.
So that's interesting. I haven't run the same analysis. The most radical aspect of the ACA is the idea that people will be good purchasers of health insurance. It's not impossible that they might be, but there's not very many people with experience, because you get given health insurance when you have Medicare. There's a benefit package that, roughly speaking, defines what then private insurance companies morph off of that, and so on and so forth. So it's really a non-trivial enterprise to figure out how to set up an exchange, a market, a purchasing mechanism to let people make good choices. And the big difference is, like in federally run exchanges, like in North Carolina, any plan that complies is allowed to be sold. So you can go in Durham last year, if you just would mess around and put my zip code in, there'd be 30 or 40 Blue Cross Blue Shield plans, and a lot of times there were 15 or 20 of them that had almost imperceptible differences, and it was very difficult to understand what they meant. So in some states that have set up their own exchanges, that they've managed them and disallowed companies from running derivative plans. And my point here is, I'm not even sure the best way to do this. I'm saying, again, the most radical part of the law really is that people will be good purchasers of health insurance. It's not impossible, and I think we can do better, but figuring out how to set up the information, and again, back to the thing I said earlier, what is a reasonable deductible? Like, the country needs to figure that out. What are we willing to say is legit for people to pay out of pocket before insurance kicks in? And I'm not sure, but in one sense, if you went to a passive catastrophic insurance, if we're going to have massive deductibles, just Medicare Part E, the E for everyone. That's what I proposed in my book, and set a deductible of $10,000 for an individual, and then set up private insurance markets with premium support without an individual mandate. That's not perfect, but the point is, with that, you could get true universal coverage.
Other questions? DC?
Well, I can comment on the last question. How about
Great,
that?
that'd be great.
The couple things about it are pretty interesting. One is that one of the great ironies of the law, 2010 law, is that it will push a lot more people into high deductible insurance plans. I'm not sure President Obama probably wants to be known as the guy who who promoted, high deductible health insurance, but that's, actually one of the realities of it. The second thing to keep in mind is that in some ways, the way to think about this is you have how much can the beneficiary contribute in terms of their resources toward their health care, and if you have it all done in premiums through prepaid health care, does that have any beneficial effect, or is it better to have them have a higher deductible where they're picking and choosing some of the upfront services? My own view is that some of the clearing out of excess costs in the system is probably occurring to some degree now, because there's now 20 million people that are in high deductible plans after enactment of a law from 2003 in the Bush administration. So I think the dynamic, the movement toward high deductible plans is actually a beneficial one, but I do agree that the politics could be dicey. One interesting point Don made is that, well, maybe there could be agreement around, hey, these deductibles are too high. In my view, I guess one way to think about why do people oppose some of the aspects of the law, I think part of it is to understand what the next political dynamic is going to be. If you have the government setting the full parameters of a benefit package, the deductibles have to be this, and the insurance plan has to cover that, and here's how much the subsidy is going to be. There's going to be another round of political action where people come in and say, it's awful that Americans have, deductibles of $5,000. We need a new subsidy program to reduce it to $2,000 or $1,500 or something, and taxpayers should pay for that. So if people are wondering what the next round of expansion will be, we've had a long history where we've had incremental expansions and entitlement commitments. The next rounds will be around that kind of thing. They'll say, yeah, we enacted this great healthcare expansion, but we need to expand it even more. And we need to lower the costs, and we need to bring the subsidies up, and we'll pay for it by taxing the rich, so to speak. So I think if you want to see where this will go in a political economy sense, that's where I would predict it would go.
Jim, when you spoke earlier, you specifically talked about Arkansas and Alaska as two states where the Affordable Care Act is front and center in the election. Are there states where it's less of an issue, and why is that? What are those states?
Well, I think there are some states where it's very much accepted. I mean, let's face it, it follows a little bit the sort of cable TV show red state, blue state political divide, right? So in some states where the law was viewed as the next natural step toward social protection, then the populace is not as ginned up about it, and probably is not ready to hear ads saying how bad it was. But in many in other parts of the country and more reddish states, so to speak, I think that message is still resonating pretty strongly. And so I expect it will be still featured as part of the political campaign over the final 6 weeks.
Man, the South is going to be in such great trouble if all the good liberals in California and Massachusetts ever figure out that they're just trucking their money down to us, and we're saying we don't want it.
Last week, I heard a Republican pollster.
We have a question here.
I heard a Republican pollster assert that ads that were run that said that Obamacare was a bad healthcare model tended to not be effective. But ads that were run that talked about government overreach with the Affordable Care Act were very effective. I was wondering if anyone had any thoughts about that or comments.
Well,
Can you repeat the question?
yeah, the question was that a pollster apparently said that the ads that said that the Affordable Care Act was a bad healthcare model weren't too effective, but ads that said that the law represented government overreach into the health system were effective. I have sort of two comments on that, and I'll turn it back to Don. But one is that I think the public kind of, in some ways, it kind of gets it right, actually, which is that that the danger with the law is not so much that, if you just isolate individual provisions of various regulatory actions, many of them would feel fairly benign. But when you accumulate the amount of power that was shifted from various other actors to the federal government, just read the statute, it invests with the Department of Health and Human Services the authority to essentially run the whole system in various ways. I think we've even witnessed that with many of the decisions that were made in the last year during implementation. And the worry in the public is that won't they eventually mess things up with that kind of authority? And actually, won't they use that authority to kind of build a power base that can never be retrenched? That is absolutely a correct understanding of how politics basically works. And so, yeah, I think that those kind of ads resonate, and probably for a pretty good reason.
Did you want to talk about this?
The Medicare program is, there's a couple of my students here, like The Godfather, I've got an offer you can't refuse, and setting prices. He said that the ship kind of sailed a long time ago, I think, on the federal government having a lot of power in healthcare. So it's interesting. I believe, Jim, that's the way at the gut level he thinks about it. When I think about it, I think, oh my gosh, we actually have set up a market where people are buying private health insurance with government subsidy, and it's the theory of it is that people could do a good job buying it. And man, if you said in the abstract that was going to happen, I would think it sounds like a Republican victory. So part of me just doesn't get it, but that's fair enough. I don't have to get it. My wife says I often don't get it. But in terms of the question about political pulse, I just don't really know. I love DVR because you just go straight through the ads. I just don't know about I don't have an evidence-based way to say anything about what ads work and what ads don't.
Could I ask a follow-on to that, to relate it specifically to North Carolina? I also understand that the ads that were run by all the independent Republican groups in North Carolina earlier this year really didn't help Tillis at all, or had a negligible bump for him. What was the focus of those ads? I never saw them.
So I'll tell you what I know based on friends of mine that are political consultants. They thought that when Speaker Tillis was running so much so early that they were, roughly speaking, helping to inoculate Senator Hagan against some of the attacks. And what they were saying to me, they said if the exchange rolls out pretty well, this will be neutral and we'll have a chance. But if the exchange goes terrible, we'll be dead. And I think, to be honest, this political strategy for both sides in this election has been hang on till about the 20th of October and then drop every dollar you've got total negative the last 10 days. And I think that's what's coming, pretty much straight character slash, and it's not going to be much about issues at all. And it's unfortunately just going to be about driving the turnout. I think that's just the way it's going to go down in North Carolina.
Did you have a question?
Oh. I was just wondering what your perspectives, both of you, are on the employer mandate, if you think that is here to stay, or if you think that's going to be something that's going to be very important going in to 2016 particularly. I think it's, as you mentioned, kind of widely accepted that it may not be necessary or it may not necessarily be a good thing, but do you think that's something that the Democrats will try to hold on to?
So I don't know anybody that's really for the employer mandate. It has no natural constituency. So I think that's the thing that goes the soonest and the fastest. And if you think about why is it there, basically the ACA is the liberal dream of single payer is not going to happen because everybody didn't live in Carver or 9th Street of Durham, right? So there was never even 40 votes for that in the House of Representatives. So there's not 10 votes for it ever in the Senate, so it's not going to happen. So it's kind of like, let's take what we've got and glom bits and parts onto it. To me, the worst thing about the law, really, if you believe radical change was needed, was that it kind of helped to lock in employer-sponsored health insurance, at least to make it the crux of the debate. So if you go back into the 90s when you had the pay-or-play notion, that was employers could either provide health insurance or pay a tax. It wasn't thought of as a sin to pay and send people into what, in those terms, were exchanged, whereas now it's kind of they're dumping to the exchange. So I think that the employer mandate is small. And you can just, if you just step back and say, why again is General Electric paying for my stepfather's health insurance? Because he's been retired for 23 years. That's crazy, right? So why did they provide health insurance to him when he worked for them? Well, it's a historical accident from the way the tax code was done during World War II. Now, of course, 75-year historical accidents have a lot of power. So I've said a lot of things, rambled, but I think the employer mandate is the part of the law that's the most likely to go away. I'm just not sure when or how.
Jim, do you have anything to add?
Yeah, just a couple of things about the substance of the mandate. It's interesting is that it's true. It's a little bit. It could be excised from the law, but maybe not quite as easy as some people think. In the sense that a very key provision of the law says that someone is ineligible for the subsidies under the exchange if their employer is offering them affordable coverage. And without collecting information from the employer community about what their offer is, you really can't enforce that provision, which is absolutely critical to the structure of the law, because if you say, well, if you can get the subsidies whether your employer is offering or not, all the low-wage workers that are in employer plans today would go into the exchanges, get the subsidies, and the Treasury's cost for financing the bill would go up a fair amount, order of magnitude much higher than was estimated when the law was enacted. And so this employer mandate is not really the same thing as the provision I described, which they call the firewall provision, trying to protect the employer coverage. But they're related, and they have to do with someone monitoring, hey, what are the employers offering to their workers? Ironically, they relaxed enforcement of the employer mandate in 2014. So one of the great mysteries of what's been going on here in the last several months is who is checking all the people that are in the exchanges to see if they got a qualified offer from their employer? And the answer is essentially no one. No one is really able to check. And so they're just basically relying on their word that they don't have an employer offer, but there's really no way to figure out if that's true or not. And so one of the maybe historical notes of what happened in 2014.
Did you have another question?
Yeah, is that okay?
Yeah.
So, this is it's really helping with a problem that I have, which is trying to explain our healthcare system to French people or like my Belgian family members. But what your point, because it's partly just that, it's such a foreign, but this idea that what we've come up with is at heart, that belief that people will make the right choice in the market, right? Kind of put into a system that's also centrally kind of governed. And because I like to defend the United States when I'm talking to French people, it's always dangerous. But I like to think about, is this possibly going to produce some kind of actually American hybrid system that can function? Because most people, for Europeans, they just find the idea that the market can do this ultimately kind of not really, they don't really think that way about it most of the time. Whereas that ours, because but the core is that belief that an individual can be informed enough about healthcare to make the right choices, right?
So I'm a big fan of markets. When in doubt, try a market. Yes, I strongly believe that. And you can introduce market aspects. Healthcare is pretty different, and there's a lot of conceptual theoretical work that shows that, and lots of practical examples. But just for an example, one of the least market provisions of the system we have now is, during the discussion of the ACA, I became obsessed with the fact that none of the Duke employees seemed to understand that when Duke paid a health insurance premium on our behalf, that's tax-free income to us. And I would go around and say, do you know how much our health insurance costs at Duke? And they would say, yeah, it costs $292.14. And that was their side. I said, no, that's your premium. Do you know how much Duke is paying? And the answer was, about 4 times that amount. And did you realize that that's tax-free income? That's excluded from your taxable income? And they would say, I don't get that. That must be a special professor benefit. I said, no, my friend. That's the benefit to people that have employer-provided insurance. And in fact, there are people at Duke with very low wage jobs. So there's somebody at Duke with the exact same health insurance I've got, but who makes $17,000 or $18,000 a year. And so they're having to string the exact same premium that I am. And so the point here is it's an upside down subsidy. The system I just described is great the higher your income is, because then your marginal tax rate is much higher. Somebody that makes $17,000 or $18,000 a year, their marginal income rate is quite low, so it's not as big a benefit. And my point here is, if you believe in markets, people not knowing how much things cost is a terrible idea.
Right.
And for 65 years, people have not known how much their health insurance
Because
costs.
it's going through the employer.
Because it came from their employer. And when you heard Aunt Marge at Thanksgiving say, Uncle Ted got a job with great benefits, she was thinking that the benefit fairy brought the benefits, and they're free. But in fact, the third biggest federal expenditure on health care is the tax expenditure, meaning the lost tax revenue from the tax treatment of employer-sponsored insurance. And I said a lot of things there again. I believe in markets. That's an example of the old system being profoundly non-market.
Right, 'cause the
nobody
employer-
understood how much things cost.
And employer-sponsored plans are actually fundamentally not choice, right? I mean,
Well,
if you choose your job, I guess, but.
in Duke's plan, I think we have 3 or 4
Right, you get choices,
options,
yeah,
but,
sometimes,
yeah.
but I mean, fundamentally, you're locked in by your
Yes, of
employer.
course.
The employers make choices,
Yes.
not individuals in the
Yes.
marketplace.
And actually, Jim probably agreed. I mean, I'm sure the first thing in most everything he's ever written about healthcare is how messed up the tax treatment of health insurance is.
But that's kind of a secret hidden, I mean, that's kind of hidden.
Secret and hidden is the key thing, yeah, because the people that are benefiting from it don't even understand they're getting it. So the point then, if you alter that, they're then, they hate it out of control federal spending in the abstract, but they like it when it benefited them. So it's really a difficult problem. And of course, the Cadillac tax, which comes in 2018, this is one of the most amazing things about law. Republicans have always talked about changing of the tax treatment of employer-sponsored insurance. The ACA does it. Then I have Dem friends, well, I'm not going to say it like that, people that should know, and I say, you realize you've already voted for that, don't you? Mm-hmm. No, we didn't. Oh, yeah, that's what the Cadillac tax is. It's a capping of the heretofore unlimited tax preference of employer-sponsored insurance. I talked too long. Jim should go for a long time now.
One might even say that the Cadillac tax was the first provision enacted in history to tax your health care benefits, something that President Obama accused Senator McCain of proposing back in 2008, for those who like a little historical anecdotes. The question, though, goes back to the issue of, can a marketplace work in healthcare? There's lots and lots of economic literature evidence that healthcare operates pretty much like every other market. If you have incentives change, you can observe what people's behavior is based on those incentive changes, and they're fairly predictable. So that if you raise the cost sharing on people, they use the service less. If you subsidize something, they use the service more. If you pay a fixed amount to lots of insurance companies are using this thing called reference pricing now, where they essentially say, we can provide this much for a knee replacement. And if you want to spend more than that and go to the more expensive provider, you can do so, but you'll have to pay the difference between the reference price and the price that provider is charging yourself. Well, lo and behold, people tend to then take the reference price and go to the lower cost provider. It's really actually not rocket science. It's basically supply and demand. And of course, it's distorted by our natural and rightful concerns about equity. So if you have everything distributed through a marketplace based on price, there's a concern that would distort the equity principle, which is that people should have more or less, if you can, or as equal as you can, access to health services because of its importance for social cohesion and their people's own individual health. So, the idea, though, that the basic laws of pricing and supply and demand don't apply to both delivery of health services as well as the marketplace for health insurance, I don't think has ever really been proven to be true. There was a famous article written in the 1960s by, and who am I to argue with him, a Nobel laureate, Kenneth Arrow, very, very famous economist, but it was a theoretical piece about why healthcare is different from normal goods, and therefore shouldn't be handled the same way as normal goods in our regulatory scheme. That's all true to some degree, but that doesn't mean that you abandon. That doesn't mean that the federal government has to run the whole thing and abandon all sense of economic principles associated with it. So I think it's in some ways a bit of a red herring to talk about markets and healthcare as if some of the normal rules wouldn't apply.
Yeah, I didn't mean to say that if that's what I said.
No, I was responding.
Yeah, I mean, I was thinking that for certainly in like a Western European context, it's a very different. But partly, I'm just thinking about whether are we building some kind of hybrid
So
system?
hold on a second. In Western European countries, some of them may have better market signals than we have, in the United States. I mean, take the National Health Service. They maintain a list of how long it is a wait for a procedure that's not an emergent one. So there's complete information. People with money go to private. That's just an example. So I really agree with Jim. That we need to introduce as many market principles as we can, and as he said, within the general notion that there's an equity concern, because the market would never cover the least of these if you think of it in that sense. So.
I have a question. So for 2016, so we have a new enrollment period about to come up. There's going to be more and more people enrolled. And can the Republicans, what would a Republican candidate's best message be in relation to healthcare? Is just straight repeal, is that still in play? Or?
Well, just for the maybe didn't hear it, the question was, we're going to have another open enrollment period soon, and by 2016 there'll be more people in the exchanges. Maybe the subtext of the question is it realistic for a Republican, probably presidential candidate, to just run on repeal? And I think the answer to that is pretty plainly no. I don't think that they could run on repeal without offering an alternative vision for where they want to go with the health system. I also wrote an article recently that was referenced at the beginning of our session here today that basically argued that if whatever is outlined as in the rubric of repeal and replace, they're going to have a program built into it that transitions from the current law, because it's an incumbent program with lots of people involved in it at this point, and the natural politics are that you're just not going to get politicians at the end of the day. They may talk about it in theory, but in practice, when the push came to shove, they wouldn't have the ability or the votes to suddenly, repeal the Medicaid expansion and just have no accommodating provision for the people that were used to be on Medicaid. So it's just the natural cycle of things. That candidate in 2016 is going to have a vision of, I don't know if they'll still be using repeal and replace in 2016. There's probably a good chance they will. But, I think the way to think about it is they're going to have to outline a vision for where they want to go with the health system. And if it's different from where the vision would be with the incumbent law, they're going to have to say, and here's how I go from that law to my new vision so that it doesn't, cause undue disruption to some of the people that are currently in the program.
I have a follow-up to that. Are there candidates that you see either in 2014 in some Senate races or people who are potentially positioning themselves for 2016 that have viable options?
Well, I think there's two plans that I'm partial to that I think, I've been around this long enough to know that there'll be continued debate about it, but the viable options will be reduced down to a couple. And so the most viable option really is Senators Burr, Coburn, and Hatch introduced a proposal. Maybe not coincidentally, none of them are up for re-election right now. Their proposal would very much change a lot of the architecture of the law, but it would have a premium. It would have a tax credit for health insurance premiums for people outside the employer system. It would have a tax limitation for the employer system, better than the Cadillac tax, more rational than the Cadillac tax, but not totally different from the Cadillac tax. And it would have additional subsidies for people on the low end, not like Medicaid, but not all that different either. And they would be additional subsidies to make sure that they are essentially in near free insurance. So, there's some structural elements that people would say, well, that sounds a little bit like the ACA. But then when you go below the surface, you realize it doesn't have, an employer mandate or an individual mandate. It doesn't have all of the regulatory aspects that they move to the HHS. It doesn't have many of the barnacles that were attached to the basic structure of the ACA. So it's a much slimmed down way of approaching the issues. And I think a Republican candidate is probably going to have to not maybe aren't that specific where they embrace that in its entirety, but they're going to have to point to a plan that roughly looks like that.
I actually agree that the Coburn-Burr hatch is the most, maybe even comprehensive and most realistic alternative, but the first 24 hours after it came out shows how hard this is going to be for, not just for Republicans, but for anyone. So I actually prefer what they said the day it came out to the Cadillac tax, and it was a capping of the tax preference at the 80th percentile. That means if you array the least expensive to the most expensive employer-provided plans anywhere, up to the 80th percentile, the bottom 80%, that's tax-free. You're going to expose the top 20 percentiles just to marginal tax rate. It's a great policy. They pulled away from it in less than 24 hours. And the reason is my friend Steve Parente did a private score of it, and they got the headline they wanted, which is going to expand insurance coverage. It's going to reduce the deficit by about $1 trillion over 10 years. And the main way it's going to do that is by capping the tax expenditure, changing the tax treatment of health insurance. And then somebody said, oh my gosh, Senator Coburn-Burr and Hatch, that's a tax increase. And so then the next day they sort of morphed the language, and then it kind of disappeared off their website. And then Parente, I was after him, he's a friend of mine, I said, dude, you got to rescore the plan now because they've changed the plan, but of course they haven't rescored it. So they've got a private score, meaning effect on the deficit, but they no longer adhere to the policy that produced that score. And in one sense, I don't blame them.
I completely and totally disagree with Don's characterization of this. Basically, it wasn't a private score; it was a public document. They misconstrued the amount of the tax cap level, and by the way, I think it's going to be quite clear that President Obama is the first one to tax health benefits. He did it through the Cadillac tax. The unions are already gunning to oppose it. So the idea that the Democratic Party can sort of, somehow attack Republicans for taxing health benefits will be completely crazy. They're the ones who did it in the first place. This would actually make it more rational.
I don't want to attack you. Hey, Jim, I'll go with you to the Commerce Committee and support the policy. I'm being serious. I don't know about the Democratic Party, but you get them to commit. And when I say private score, I mean not CBO. I'm saying I'm all for it. I told Senator Burr, man, great policy. I will go with you, Jim, to the Commerce Committee and say this is an incredible policy. We should change the Cadillac tax away for this tomorrow. Just to be clear.
Okay. Well, maybe you and I can agree, but let's see what happens. But I guess my broader point though is that if someone was going to sell, a Republican candidate is not going to be able to sell an alternative based on, well, my Cadillac tax is not, worse than your Cadillac, is less worse than your Cadillac tax. That's not really what they're going to be saying. They're going to say, look, here's a way to cover a lot of people in America with health insurance that doesn't involve massive governmental intervention that they have through the ACA. It doesn't include the Department of Health and Human Services telling essentially all 300 million of us, here's what you got to have in your benefit package. It doesn't have the authority for HHS to say, here's how every state has to regulate their health insurance. It doesn't have the individual mandate with this new tax that the IRS is going to collect on people that go uninsured. And it doesn't have the employer mandate with the massive reporting requirements that are associated with it. I think that kind of message, if it's sold right, would actually resonate. Because most people have looked at it and said, yeah, a lot of these provisions are totally over the top. So we'll see. I have no idea if a candidate will take it up and run on it that way, but I don't see much more of a viable option than to do so.
And actually, just one thing, it surprises me. I mean, for conservatives for like 30 years have been saying the biggest problem with the health system was tax preference spending through employer-sponsored insurance. I actually completely don't get why conservatives wouldn't say, I guess maybe none of the politicians were ever willing to vote for it, but certainly all the conservative wonks. I mean, that's like a number one thing. So anyway.
I think we have time for one more question if there's one here.
We have one here in Washington.
Great, let's do it.
I think, and we've been around and around on this. Some analysts say that the lack of tort reform is a big driver in the escalation of healthcare costs, where doctors have malpractice premiums that are $1 million or more a year, and that both parties are going to have to try to deal with limiting liability because doctors practice a lot of preventative medicine. And if we can somehow reasonably reform the tort system, that would be an aid in bringing down healthcare costs. Comment on that.
Well, I can go first, Don, or you could. I don't care.
Go ahead.
Okay. Well, the evidence from the literature is that it would be beneficial, but maybe not quite as much as some people would hope. That it would have some positive impact on costs if you had a uniform nationwide system of limited liability for non-economic damages. But enacting that is pretty tough, Yeah. But if you did that, it could bring down costs, based on some prior literature, maybe 3, 4, 5%, who knows, but somewhere in that range maybe. And it's a one-time thing, and then you kind of continue on. I think the thing to understand with liability is that what you want to do is break the cycle of jury awards kind of reestablishing the standard of care. So what happens is, a physician takes care of somebody, something goes wrong, they go into a malpractice suit. The law is supposed to say, hey, did the physician follow the standard of care for that community? What's usually done for a patient with that condition under that circumstance? What does the science say? What is the physician supposed to do? And if you have a jury that's always deciding these things, lay people deciding it, they can always say, well, they should have done this. Here's the standard of care that from the, and so that ratchets up the standard of care over time, and of course it never goes back down. Yeah. So removing some of the decision making about what the standard of care is from the court system is sort of the idea behind all of this, okay? Mm-hmm. And I think that's a good idea. That should be done. It's complicated about how to do it.
Yeah, just quickly, it shows you this is an example of the weirdness of health policy. The Dems say states' rights, let states decide. The Republicans want a federal standard, so they kind of go like this. In general, it'll save a little bit of money, but it's mostly a political thing. It's probably an important political thing. And actually, there's a patient safety crisis. So they both need to be dealt with together. And I actually would be for moving malpractice out of the normal courts and into more, I guess you mean more basic health courts. But basically, there's as much or more probably of a patient safety crisis than there's a malpractice crisis.
So it's 5 o'clock. I want to thank Don and Jim so much for doing this, and also the Forum for Scholars in the Public, so Duke in Washington. And we'll see you again next week at 4 o'clock, same place, same time. Thank you.
Thank you.